sodium balance. So my objectives are that I hope by the end of this talk, you will understand the principles of water and sodium balance, understand the pathogenesis, approach, clinical presentation, and treatment of disorders of sodium balance, and understand how to perform calculations of fluid and sodium requirements. And this talk will lay the groundwork for a follow-up talk where we focus in more on disorders observed in chronic kidney disease and their treatment. So before getting into fluid and sodium balance, we have to go through a couple core principles. So one of those principles is total body water. Now, total body water is a proportion of body weight, and it's inversely related to adiposity. So the higher your total body water, the lower the adipose tissue. And so that is why we see that total body water is 80% in our small neonates and up to 65% in children and around 50 to 60% in adult males and females. Now, total body water has two main compartments. There's the intracellular fluid and the extracellular fluid. And the compartments are separated by a semi-permeable membrane. And what that membrane does is maintain the solute composition of each of the individual compartments. Now, the compartment sizes do change with age. Again, as in the picture I just showed, the extracellular volume, the extracellular fluid is greater in our small infants who have higher total body water, as well as our young children compared to adults. And this is just a picture because I always think more visually that if we think about an adult or small child, if they are 60% around total body water, a third of that is your extracellular fluid, 2/3 of that is your intracellular fluid. And then this extracellular fluid compartment is further broken down into plasma and interstitial fluid. Now, just as I just showed, the intracellular fluid is 2/3 of total body water, so the majority, and the primary electrolytes that are found there are potassium and your organic phosphates. Now, extracellular fluid is only 1/3 of total body water. As the picture before showed, it's made up of interstitial fluid and plasma. And really, the primary electrolytes of the extracellular fluid include sodium, chloride, and bicarbonate. So another key term that's important to understand when thinking about fluid balance and electrolytes is effective circulating volume. And now effective circulating volume refers to the part of the extracellular fluid that is within the vascular space and effectively perfuses tissues. So changes in extracellular volume tend to follow changes in extracellular fluid, and both vary based on your sodium stores. And that means that high sodium load in the extracellular fluid means that you have effective circulating volume expansion. The ECV is bigger. When there is sodium depletion or in states of sodium depletion, especially in the extracellular fluid, you will have effective circulating volume contraction. Effective circulating volume is maintained by hormonal regulation of vascular resistance, cardiac output, and renal sodium water excretion. Now, the hormonal mediators that affect your effective circulating volume include the renin, angiotensin aldosterone system and whether it is activated or inactivated. It also includes your sympathetic nervous system, as well as natriuretic peptide secretion. And we'll see that in our next picture. So when I talked about this effective circulating volume and what happens, whether it's high as in the first picture or low, when we think about the different mediators like the RAS system, as well as the other players, hormonal regulators, in states of high effective circulating volume, so really your volume expanded states, the juxtaglomerular apparatus of the kidney, baroreceptors that are low pressure baroreceptors, and those are found in places like the atrium of the heart, as well as high pressure baroreceptors, which are found in places like the carotids. They are then activated. For the juxtaglomerular apparatus, it decreases RAS activation. In these low baroreceptors in the heart, specifically the atrium, it increases atrial natriuretic peptide. And in these high pressure baroreceptor sensors, it decreases sympathetic nervous system. And all of that acts to inhibit renal sodium and water retention. So if your volume expanded, you have high effective circulating volume, then you have both your kidneys and these baroreceptors that say, we don't want to hold on to sodium and water, which will help decrease this high effective circulating volume state. And the opposite is what you'll see in a low effective circulating volume states. When your volume down, you have the opposite. We have RAS activation, like we see here in the bottom picture. We have antidiuretic hormone increases so that you have water retention, and you have sympathetic nervous system activation, all of which increase or activate renal sodium and water retention, as well as increase vascular constriction, as well as heart excitation in order to increase blood pressure and increase your effective circulating volume. Another important term to understand before we dive into fluids and electrolyte balance is plasma osmolality. So osmolality is a measure of solute concentration in a fluid. Now, the primary plasma solute is sodium. In smaller quantities, we also think of osmolality being affected by potassium concentration, calcium, glucose, and urea concentration. And it's important that we know how to calculate plasma osmolality. Any patient that you might see with a disorder of fluid or especially sodium balance, one of the first things you're going to want to understand is their plasma osmolality. And that is calculated by multiplying 2 times your sodium plus your glucose divided by 18 plus your BUN divided by 2.8. And these are in milliequivalents per liter for your sodiums, or millimoles per liter, milligrams per deciliter for your serum glucose and your BUN. And a normal plasma osmolality is between 280 and 295. And I want to make sure we understand the difference between osmolality and tonicity. We often use them interchangeably, but they're not quite the same. Osmolality refers to total concentration of all the particles in a solution. Now, tonicity really refers to the concentration of only the osmotically active particles. That means the particles that drive water distribution. And really, tonicity focuses on, or is defined by, only impermeable particles that contribute to tonicity. And one of the things that's important when we think about chronic kidney disease, where osmolality and tonicity are not quite the same, would be urea. So urea can easily equilibrate across a membrane. Therefore, it has very little effect on water movement across the cell. So in states of high urea, like we have with renal failure, the plasma osmolality may be increased, by the accumulation of urea, as in the states of, let's say, renal failure, but the plasma tonicity is unchanged, again, because this urea can rapidly equilibrate. And now, in thinking about tonicity, and when we think about fluids, there are three major types of tonicity to our fluids. We have isotonic fluids, which cause no net water movement. We have our hypertonic fluids, which causes net flow of water out of the cell. And then we have our hypotonic fluids, which causes net flow of water into the cell. I always say that water is going to want to go where the party is. So in our hypertonic fluids, all of that solute and sodium is outside of the cell, which is why water is driven to that area outside of the cell. With our hypotonic fluids, there is more sodium inside the cell or more solute inside the cell, which is why hypotonic fluids causes net flow of water into the cell, because water wants to go where the party is, where all the other particles are. And this is just a quick schemata that looks at the typical fluids one might be used to and what they are in terms of osmolality as well as tonicity. So we know that normal saline is an isotonic fluid. This is why we use it to rehydrate someone or give them a bolus. Half normal saline is a hypotonic fluid. Lactated ringer, which is often used after surgeries, but have to be used with caution because they do contain electrolytes like potassium, which is why they often are used cautiously in patients with chronic kidney disease, but it is an isotonic fluid. One of the things that's interesting to note is D5 water. While we think about that as a very hypotonic fluid, it's actually isotonic, but because glucose can rapidly, dextrose is rapidly metabolized, it's thought to be physiologically hypotonic, but in and of itself, it's an isotonic fluid. So now that we understand those principles, just going to do a quick time. We can now get into our disorders of sodium balance. And we're first going to start with hyponatremia. So hyponatremia is defined as a serum sodium of less than 135 milliequivalents per liter. Mild hyponatremia is when your serum sodium is between 130 to 134. Moderate hyponatremia is when the serum sodium is between 120 and 129. And severe hyponatremia is defined by a serum sodium of less than 120. Now, the pathogenesis or the cause of hyponatremia is that you have free water excess along with impaired excretion of free water. And now antidiuretic hormone, or ADH, is the primary hormone for water regulation. The primary determinants of ADH release are increased plasma osmolality, which is why I went over sort of the principle of osmolality first, because ADH is dependent, or ADH release is determined by increased plasma osmolality as well as decreased blood volume. So decreased effective circulating volume. So this is, I think, a really nice visual of how ADH works. So we have vasopressin. Arginine vasopressin is another name for antidiuretic hormone, and it's released by the posterior pituitary. It travels in the bloodstream, and what it does is it binds to this vasopressin 2 receptor in the collecting duct. That receptor then goes on. I don't know if you guys can see my mouse. Can you? So maybe I should do it by numbers. So in step 1, we see that vasopressin, which is the same as ADH, binds to this vasopressin 2 receptor. In step 2, that is after vasopressin binds to its receptor, it activates cyclic AMP, this sort of second messenger system. In step 3, the activation of cyclic AMP really tells these aquaporin two vesicles that are within the cell to go ahead and attach themselves to the tubular side of the cell, which allows for water to pass from the collecting duct to be absorbed into the blood. And that passage of water is by osmosis. But really what's triggering this ability for water to be reabsorbed into the blood is that vasopressin, which is ADH, is secreted by your posterior pituitary, attaches to its V2 receptor in the cortical collecting duct, which then tells these aquaporin vesicles to attach themselves on the tubular side, or where your urine filtrate is coming in, to allow water to be reabsorbed from your urine back into the blood. This is a nice picture of how we describe what is the most potent driver of ADH release. Here on your x-axis, you have plasma osmolality. And typically when your plasma osmolality is low, you wouldn't want to activate ADH, because ADH would say, let's reabsorb water. But in states of low plasma osmolality, you don't want more water. However, what it shows here on the left is that if you have a decrease or a significant decrease in your effective circulating volume, that's an even stronger driver for ADH release. So that's why you may see ADH release and water retention even when your plasma osmolality is low. Now this looks like a very busy and confusing slide, but we're going to take it bit by bit. But what this algorithm shows is a very systematic way to approach hyponatremia. And this is sort of what you want to be thinking of when you're called either as a general pediatrician or trainee, or even for one of your CKD patients, if they are noted to have a low serum sodium, also known as hyponatremia. So the first thing you're going to want to do if you're called about a patient who has hyponatremia, independent, we'll get into the etiologies, and this is going to help you find what's the cause of the hyponatremia. You want to measure the serum osmolality. Now, I described that a serum osmolality can either be normal, which is around 280. It can be elevated, which is greater than 280, or it can be low, which is less than 280. So we're going to go through each of these states. So the first we'll go over is isotonic, meaning the serum, the patient is hyponatremic, but the osmolality that you've calculated is normal. And that's what you're going to see in pseudohyponatremia. This can occur in states of really high cholesterol, and really it's a not true hyponatremia. It's more that your testing is affected by this high triglyceride state. I won't spend too much time on this, and we'll spend more focused time on the hypotonic hyponatremia. Before moving on to that, I'll quickly say a word about hypertonic hyponatremia. This is when your osmolality is elevated, and you can see that with hyperglycemia. So again, if a patient comes in, they are observed to be hyponatremic, calculating that plasma osmolality can easily tell you isotonic, okay, it's pseudohyponatremia, look at their lipid panel. If they're hypertonic osmolality, think about patients with really high glucose levels. But for the remainder of the talk, we're going to focus on true hyponatremic dehydration. I'm sorry, true hyponatremic, hypotonic hyponatremia. Okay. So in your hypotonic hyponatremia, the next thing you're going to want to look at after you've calculated your plasma osmolality and said, okay, this is true hypotonic, then it's a matter of looking at their volume state. So in hypovolemic hypotonic hyponatremia, you have both low total body water and low total body sodium. And in these cases, your effective circulating volume is low. So these are like your dehydrated patients. If that's the case, there could be multiple things causing that. So the next step after calculating your plasma osmolality is to then look at your urine osmolality. If your urine osmolality is very elevated, you then also want to get a urine sodium. So 3 things you're going to want from the beginning, if possible, when a patient comes in with concern for hyponatremia, calculate their plasma osmolality, also get a urine osm and a urine sodium. And that's going to help you decide sort of what might be causing this hypotonic hyponatremia. If your urine sodium is low, so this would be in cases of hypotonic hyponatremia, you'd want your low urine sodium if the kidneys are acting correctly, because you're going to want to hold on to the sodium. Since your serum sodium is low, you don't want it in your urine. So low serum sodium tells me it's probably nothing going on with the kidney, and you want to think of non-kidney causes like vomiting or diarrhea, or patients who have third spacing from things like a severe burn. If a patient is hyponatremic and you see that they have a high urine sodium, this is when the kidneys are likely not acting as we'd expect. We think about renal losses, we think about diuretic use, which we know blocks your sodium retention. We think about any problems with aldosterone deficiency. And this is a very busy slide, but specific to CKD, you would see this hypotonic hyponatremia with an elevated urine sodium in cases of conditions such as Barter's syndrome, like we have here, Gittleman syndromes. These are salt-losing tubulopathies, as well as pseudohypoaldosteronism. And while this talk is mainly to go over principles and identifying causes, our follow-up talk in part 2 will go through these conditions and their clinical presentations in more detail, as well as treatment. But really the take-home point is a hypotonic hyponatremic patient, meaning they are volume down with high urine sodium, think kidneys. And that's when we want to start thinking about things that could be chronic kidney disease or inappropriate kidney function. Now, we've already talked about hypovolemic states with hyponatremia. Now, we're going to talk about hypervolemic hypotonic hyponatremia. And so this is hyponatremia, but you're actually fluid overloaded. So your total body water is high, as well as your total body sodium is also high. And the reason these patients are hyponatremic is because they're holding on to more water than they are salt. Much like our other case of hypovolemic hyponatremia, you still want to use your urine osm, which in this case would be greater than 100. And then again, look at your urine sodium to direct you as to thinking about which diseases might be causing this hypervolemic hyponatremia. In these states, if the urine sodium is less than 20, again, first things you should think about are things like cirrhosis or non-renal causes like heart disease, but we also, more specific and pertinent to kidney disease, we see this in our nephrotic syndrome patients. So these are patients who may come in relapse for their nephrotic syndrome, or this is their first presentation where they're puffy. So they are hypervolemic, meaning volume expanded, and they're holding on to more water than salt, which is what causes their serum sodium to be low. And so that would be the case of low urine sodium, because the kidneys are still acting right in terms of trying to hold on to sodium, but there's something else at play, like with nephrotic syndrome, where they're losing protein and they have low oncotic pressure that causes them to swell. If the urine sodium is greater than 20, the kidneys are not functioning correctly, and we see this in cases of acute or chronic renal failure. Again, this is where we have the kidneys aren't functioning right. It's losing salt in the water. We're using salt in your urine, but you're holding on to much more water than you are salt, which is what causes you to be hyponatremic, but hypervolemic on exam. And the last state is euvolemic hypotonic hyponatremia. This is when the patient is neither volume contracted or dehydrated or volume expanded and puffy like a nephrotic. They actually are euvolemic on exam and have no edema at all, but are hyponatremic. This is where you have normal total body sodium, but you're holding on to more water. Just as in our other cases, our urine osm and our urine sodium will direct us as to what might be causing this euvolemic hypotonic hyponatremia. On the left side here, if your urine sodium is greater than 20, you want to think about conditions such as hypothyroidism or glucocorticoid deficiency, or really what we see more as nephrology providers and providers who manage patients with CKD is a syndrome called SIADH, the syndrome of inappropriate ADH release. This is specifically seen in, or a specific case that you can think about that's relevant to nephrology would be your patients that you follow for CKD due to an oncologic process. It may be the drugs that they're taking, like cyclophosphamide, for example, that causes this inappropriate release of ADH. And that's why these patients hold on to water and are hyponatremic and have high urine sodiums. In patients where the urine sodium is low, really you're thinking about people who just drink a ton of water or don't take in enough salt, and that's your primary polydipsia patients. This might be a psych patient drinking liters and liters of water, or a patient who is drinking lots of alcohol and not eating enough. That's going to be your patients who are euvolemic, so they're not puffy, they're not dehydrated. Their urine sodium is low, but their serum sodium is also low, and really it's just they're taking in too much water. So that's sort of our approach to thinking about when a patient is hyponatremic. Our next step is to calculate the osmolality. True hyponatremia is a hypotonic hyponatremia. And the next step you want to do is look at their exam. Are they dehydrated? Are they puffy or swollen or edematous? Or are they euvolemic? And then using mainly your urine sodium to dictate what might be causing this hyponatremia. In terms of the clinical presentation in general of hyponatremia, really, it's dependent on the duration and the severity of the hyponatremia. So the body will tolerate chronic changes or slower changes much better than acute changes. So acute changes in sodium, typically less than 48 hours, or more likely to be associated with symptoms. Symptoms typically present once the serum sodium is less than 125. So your patients with sort of the milder 128, 130 are unlikely to be symptomatic, but these patients with very severe hyponatremia will likely be symptomatic. And the symptoms are primarily neurologic. So that includes nausea, vomiting, lethargy, headaches. At its most severe, it includes seizures and herniation and death. And the reason for the symptoms primarily being neurologic is that the brain to skull ratio, especially in children, they only have so much room, and we know that water wants to go where the party is. So if you're hyponatremic, that water is going to flow into the cell. That cell is going to swell, and you only have so much room, brain to skull in children. And that's primarily why we see neurosymptoms and why at its worst, it could be seizures or herniation. In terms of the treatment of hyponatremia, again, it depends. For asymptomatic hyponatremia, the goal is correction of the sodium to no more than an increase of 8 to 10 milliequivalents per 24 hours. Again, if someone corrects very rapidly and they've been hyponatremic for less than 48 hours, they're likely to tolerate rapid correction, and we'll go into why rapid correction is concerning in the next slide. But typically when you have your hyponatremic patient, you're aiming to correct their serum sodium by no more than 8 to 10 milliequivalents in a 24-hour period. If the patient is hypovolemic, hyponatremic, meaning you're a dehydrated patient, then the treatment is to volume expand them. These are the patients that often get a normal saline bolus on presentation if they come in with multiple days of either vomiting or poor intake. Their hyponatremia is best treated by volume expansion. In our hypervolemic hyponatremic patients, an example of this again would be a nephrotic syndrome patient. You can think about fluid restriction, so they're not taking in so much water, as well as using diuretics. In very severe cases like renal failure, then we need to do fluid removal by renal replacement therapy, or RRT, in order to correct that serum sodium. In our euvolemic patients, like those with SIADH, or the syndrome of inappropriate antidiuretic hormone release, like the cancer patients I talked about, that you'd want to, the treatment for that is fluid restriction and then potentially sodium supplementation. So that was asymptomatic hyponatremia. Now the patients that come in that are symptomatic from their hyponatremia, the treatment is hypertonic saline. Really, hypertonic saline should be used in cases where there are neurologic symptoms such as seizures or altered mental status. The dosing for hypertonic saline is pretty wide. Typically, you're starting at anywhere from 1 to 5 milliliters per kilo per hour as initial rate of therapy, and often you're giving your initial dose and checking the serum sodium 1 to 2 hours later, because again, we want to treat so that the symptoms stop, like a seizure, or the patient who's altered regains consciousness and is alert and oriented again, but we would want to try to correct to avoid rapid corrections. Again, the rate of correction, even if a patient needs hypertonic saline, we aim to not increase serum sodium more than 8 to 10 milliequivalents in a 24-hour period. And the rate of correction for the first 2 to 5 milliequivalents per liter, you want to give that rapidly. So you want them to give it until they're no longer altered or having seizures. And then after that, you can aim for your 8 to 10 milliequivalents per liter in a 24-hour period. And the reason that we don't want to correct hyponatremia rapidly or too fast or more than that 8 to 10 milliequivalents per liter in a 24-hour period is because of something called osmotic demyelination syndrome. It is rare. The incidence is about 0.6 million person years if the initial sodium is greater than 120. The incidence can be as high as 50% if the initial sodium is very low, less than or equal to 105 milliequivalents per liter. And it's caused by rapid correction of severe and chronic hyponatremia. It's possible that even if a patient were to experience osmotic demyelination syndrome, that it may be reversible. If we have time, I can give you some data on recent studies about that. And we don't really understand the pathogenesis of osmotic demyelination syndrome. However, we think that the chronic hyponatremia is associated with the loss of these osmotically or water-active organic solutes from the astrocyte cells in the brain, and that protects against brain swelling. So the osmolytes cannot be as quickly replaced when the brain volume begins to decrease or shrink when hyponatremia is corrected rapidly. And that means if we bring that serum sodium up too fast, the water that's in the cell, again, wants to go where the solutes are, it's going to go out of the cell. And that's why the cell shrinks. With rapid hyponatremia correction, the loss of water from the cell, coupled with movement of things like potassium and sodium back into the cell, cause an initial increase in the cell cation concentration before the repletion of these organic osmolytes. And so really what you have is this end result of all of this is the direct rapid correction causes direct injury and cell death of these like protective astrocytes that are critical for really the myelination of the cell, myelination and demyelination of the cell, which are important for maintaining the blood-brain barrier. So previously, because this is rapid correction causes this defect in myelination. This is why it was previously called central pontine myelinosis. Okay. In terms of risk factors for osmotic demyelination syndrome, liver disease is a risk factor, malnutrition, hypoxia, or as I mentioned, correction of the serum sodium, typically greater than 18 to 25 milliequivalents per liter in the first 48 hours of therapy. Typically, it follows this what's called biphasic pattern. So initially, the patient has clinical improvement of their hyponatremia symptoms, and then subsequently, they have this neurologic deterioration or neurologic decrease 2 to 7 days following the correction. So this is something that presents days after rapid overcorrection of hyponatremia. The symptoms of osmotic demyelination syndrome are mutism or inability to talk, disordered movement like dysarthria, spastic quadriplegia, pseudobulbar palsy, which is when you're kind of like a sort of paralytic state, ataxia, and this locked in stare. So you're staring, but you can't move. And it's best diagnosed by MRI. And typically, because it can present so many days after rapid overcorrection of hypernatremia, you may not actually see the lesions in the pontine region of the brain until up to 2 weeks later. Okay, hypernatremia. So this is defined as a serum sodium of greater than 145 milliequivalents per liter. Really, for hypernatremia, the pathogenesis, or it's caused by loss of free water or bodily fluids with lower sodium concentration than plasma or sodium. It may cause movement of water out of the cell and cellular contraction, because again, if water is going to want to go where your solutes are. So if you have lots of sodium outside of your cell in your extracellular fluid space, the water is going to flow from the inside of the cell out, and that's what causes your cellular shrinking. The major defense that the body has against hypernatremia is an intact thirst and access to free water, as well as an intact ability of the kidneys to concentrate your urine. This is often why we see, unless we're talking about things like renal failure, we see hyponatremia much more than we see hypernatremia, because patients who have access to free water and whose brains work appropriately to trigger thirst can usually maintain, sort of treat themselves for this hypernatremia. Much like with hyponatremia, once you've confirmed that you are dealing with a patient that has a high urine sodium, you want to again get your plasma osmolality and your urine osmolality. You can calculate your plasma osmolality and you send for urine osmolality, and that helps you decide sort of what might be causing your hypernatremia. If your plasma osmolality is greater than your urine osmolality, you want to think about a urinary concentrating defect, such as diabetes insipidus, whether it be central, meaning there's a problem with the brain releasing your vasopressin, or nephrogenic, meaning the kidneys may be resistant to vasopressin. We can also see it in kidney disease, and we'll talk about that in a second, as well as osmotic diuresis, meaning you're using things like diuretics and that help excrete lots of free water, meaning that your serum sodium can then bump up. If your urine osm is greater than your plasma osm, you're thinking about non-renal causes such as GI losses or severe burns, or excess sodium intake, like someone who, like psych patient, for example, who's eating tons of salt and not drinking enough water. So when I talked about a urinary concentrating defect, again, this is the patient who is hypernatremic and their urine osm is less than their plasma osm, meaning you are not excreting you're excreting much more free water and not concentrating your urine. Really, we're looking again at vasopressin. So we mentioned that vasopressin is released by the posterior pituitary, and it binds to this receptor in the cortical collecting duct. Now, nephrogenic diabetes insipidus is either caused by a defect in this vasopressin 2 receptor, and that's going to be the majority of patients with nephrogenic DI. But it can also be caused by a defect in part 3 of this series of reactions, which is a defect in the aquaporin, the genes that encode for these aquaporin channels. But mainly you're going to see it in patients with nephrogenic diabetes insipidus. It's mainly going to be a defect of this vasopressin 2 receptor. And then I mentioned briefly about renal disease being able to being the cause of a concentrating defect. And that's because in states of like chronic kidney disease, especially when it's advanced, you actually have more solute excretion per functioning nephron, as well as decreased expression of vasopressin 2 receptors, both of which are going to predispose to becoming hypernatremic. In terms of clinical presentation of hypernatremia, really just like hyponatremia, it's dependent on severity and the rate of rise in the serum sodium. Much like hyponatremia, it's also primarily neurologic if a patient is going to be symptomatic. In patients who have hypernatremia, they may be irritable. Classic for providers who are generalists might be the baby who's at home and inconsolable and irritable. They also mentioned these babies may have like a doughy or velvet-like skin when they're hypernatremic. Other symptoms may be vomiting, weakness, altered mental status, or seizures. Chronic hypernatremia is often asymptomatic because the brain can sort of adapt when it's a slow process. When it's a rapid increase in your serum sodium, those are the patients who are more likely to be symptomatic. Treatment of hypernatremia, again, much like hyponatremia, is dependent on the duration. So chronic hypernatremia should be corrected more in 48 to 72 hours. Typically, we say 48 hours. You want to correct the serum sodium or lower the serum sodium by no more than 8 to 12 milliequivalents per liter per day, which is equivalent to about 0.5 milliequivalents per liter per hour. Treatment really for hypernatremia revolves around repletion of a free water deficit, because we said that in these states of hypernatremia, it's really that not necessarily that you are taking in too much salt, it's more that you're losing too much free water. So that's why treatment relies on replacing your free water deficit. You can also, it also relies on restriction of continued free water losses. So in our patients who are like nephrogenic diabetes insipidus, central diabetes insipidus, where they don't make desmopressin, which is the ADH analog, you can give them that exogenously. For treatment of hypernatremia, it may require fluids with sodium initially in the resuscitation phase. And when you're resuscitating a patient, you also always want to resuscitate with isotonic fluids. And over time, you can then lower the tonicity to slowly lower your serum sodium, again, by no more than 8 to 12 milliequivalents per liter per day. The reason that we care about not lowering the sodium too much is because of cerebral edema that can be caused by rapid sodium lowering. The cerebral edema, again, this is just a schematic to show that, much like I said before, water is going to want to go where the party is. So if you have all this salt outside of the cell, initially water is going to flow outside of the cell. When you then rapidly lower that, you then have water that flows back into the cell, and the cell can swell, and that's what can cause your cerebral edema. Now, I wanted to stop for a second. Diane, I was going to go through calculations, actually, of fluids, but I didn't know if I should stop there and take questions or continue going.
I think it is maybe continue 10 minutes.
10 minutes, okay.
10 or 15 minutes, yeah.
Okay, so I wanted to end by going through how to calculate fluid needs of a patient in probably the most common ways that we see it, which is dehydration. And we know that dehydration can either be hypernatremic or hyponatremic dehydration. But it's sort of one of the core principles that we want to have, whether we are practicing nephrologists or generalists. And so it starts with the case. In the interest of time, I'll sort of read through it and highlight the important parts of it that will be relevant for us calculating our fluids. So the case says that this is an infant presents with a 4-day history of vomiting and diarrhea. The mother has only been giving him water to drink for the past 2 days. He now refuses to take any liquids. On physical exam, he's afebrile but very lethargic. His anterior fontanelle and his eyes are sunken. He has marked tenting of the skin of his abdomen. So we're getting a story for a patient that's dehydrated. His extremities are cool with a cap refill of 4 to 5 seconds. He has tachypnea and clear lungs. His blood pressure is 55/34, so we know that he's hypotensive, and he currently weighs 5 kilograms. Lab results show a serum sodium of 120. So this is a hyponatremic dehydration patient, and we describe his volume status as hypovolemic. He is estimated to be 10% dehydrated by clinical signs. His wet weight, or the weight when he's well, is 5.5 kilograms. On presentation, he receives a 110 ml fluid bolus, which is 20 ml per kilo of normal saline. Additional sodium needs to correct to a serum sodium of 130. Again, we don't want to correct more than 8 to 10 milliequivalents per liter in a day. So when this patient comes, since the patient isn't showing signs of seizures or altered mental status, we call him asymptomatic. We don't have to go to hypertonic saline. What we can do is mainly resuscitate him and then calculate his sodium and water needs. So we want to aim for serum sodium of 130 in the next 24 hours. And the way that we calculate that is we take his well weight, which is 5.5 kilograms, his total body water, which is 0.6, and then we have the sodium goal that we're aiming for. which takes the goal that we want, 130, minus the 120, which is his current serum sodium. And so that gives us his sodium need to get to where we want him to by tomorrow, but we'll go through piece by piece. What are the other things we have to account for? So dehydration, in the interest of time, I'll really flow through this. Dehydration could be isonatremic, hyponatremic, or hypernatremic, but we know in this case, we're dealing with hyponatremic dehydration. Clinical signs of dehydration, we think about things like what the skin turgor looks like. We think about pulse rate, blood pressure. It's important to know that even in mild forms of dehydration, urine output may be decreased. Important to understanding what fluids a patient needs is understanding their maintenance fluids in addition to their serum sodium. I think I will skip through this because I believe that we all sort of understand how to calculate maintenance fluids and get to the main point. So when you have this patient, sodium of 120, we're going to aim is not seizing, not altered. Our goal is to get to 130 safely by tomorrow. We know his current weight is 5 kilograms, but his well weight is 5.5, and he's 10% dehydrated. And we know that his additional sodium need is going to be 33 milliequivalents. This is the chart that I often draw for myself and my fellows whenever we have a patient like this. And really, we're just going to focus on water and sodium needs. So when we think about, so I just want you guys to look at the first two columns. When we think about going through his water needs, so we know that for the first 10 kilograms, the patient is going to need 100 mLs per kilo for their maintenance. And that's why this patient, using his well weight of 5.5 kilograms, his maintenance IV fluids would be 550 in a 24-hour period. When we think about his sodium needs, just his maintenance sodium needs, not even getting to the additional sodium, just his routine maintenance, every child is going to need 3 milliequivalents of sodium for every 100 ml of their maintenance IV fluids. And so that is why in this case, 3 ml for the 550 mLs of his maintenance means that his sodium need just for maintenance would be 16.5 milliequivalents. Then we think about what are his deficits, both his sodium deficit and his water deficit. We said that this patient is 10% dehydrated. That means when we think about dehydration, we say that we want to calculate the fluid deficit by saying 10 ml for every percent dehydrated they are. 10 ml per kilo, for every percent dehydrated they are. So if we're saying that this patient is 10% dehydrated for every kilo that they weigh, then that means we are looking at using the current weight of 5 kilograms plus the 10 ml per kilo, because he's 10% dehydrated. That means his fluid deficit in total would be 500 ml. This gets a little tricky because when we think about his maintenance, we're using his well weight, the 5.5. When we're looking at his water deficit, we're looking at the current weight. So for 10% dehydrated patient whose current weight is 5 kilos, his water deficit is 500 ml. We'll base his sodium deficit based on this 500 ml. And we know that for 8 milliequivalents of his water deficit, that's going to be his sodium need. And that's why this patient, his sodium deficit would be 42 milliequivalents. So we have two things here. Our first line is just maintenance. Our second line is looking at how dehydrated he is and getting the total water needs or how his water deficit, and then looking at his sodium deficit based on that water deficit. And the last thing that we have to look at are two things. The additional sodium deficit, meaning what's the additional sodium that we need to get to the 130 by tomorrow, compared to the 120 that we're at today. And they calculated that for us. It's at 33 milliequivalents. So we have to add that in thinking about all of his sodium needs. And then we have to subtract out the sodium that he's already gotten from the bolus. So we know that he got 110 mLs of normal saline. In normal saline, there are 154 milliequivalents of sodium in a 1 liter bag. So in that 110 ml he got of normal saline, he got or received 16.9 milliequivalents of sodium. So we're going to subtract that out from his needs because he's already gotten some sodium. So in the end, when we calculate this last line that says total, we're going to add up our maintenance water needs. We're going to add up our deficit because we're 10% dehydrated. We will subtract out the fluid that we got from our bolus, that 110 mLs. And that means for this baby, his total water needs in a 24-hour period would be 940 ml. In the second column, we have that first line, which is his maintenance sodium, what he needs just on an everyday basis. We have the amount of sodium that he's missing based on how dehydrated he is. That's that second line, and that's 42 milliequivalents, and it's based on his fluid deficit of 500 ml. And then we need additional sodium that we want to give this patient to get him from the 120 he is right now to the 130 tomorrow. And that's our 33 milliequivalents, the third line. Before we can add everything up, we have to remember he got a normal saline bolus and we want to subtract that out. And so those 16 milliequivalents of sodium he got in his bolus, we subtract that. And that means in a 24-hour period, this patient needs 74.6 milliequivalents of sodium with 940 mLs of water. If we think about what kind of fluid that is, that's pretty much half normal saline. So this patient would be best at getting half normal saline. We divide that 940 by 24 hours to get the rate of his fluids, which would be 39 ml per hour. And we've already talked about hypocorrection. Since I'm over time, I was going to go through hypernatremic dehydration calculations, but I'll actually stop there so we can get to some questions. Yeah. Yeah, and I was going to stop here just because, just in the interest of time, and I wanted to get to any questions people had.
Hai anh Hoàng.
Just so I can see everyone, I'm gonna.
Let me see.
So really the take-home talk so far for this is that we have our core principles that we understand about how we think about fluid and sodium balance. Any of our sodium abnormalities, you're going to want to calculate a plasma osm, also obtain a urine osm and a urine sodium, and that will help you drive what might be causing it. And then we just went through a case of how to calculate fluid needs and sodium needs for a patient that comes in who's hyponatremic and dehydrated.
Hello. Hi, Denver. Something wrong. I think. Hey.
Sorry about that. My computer died.
I stand for
Nói được, nói đi. Em không nói được. Nói đi. Hello. Excuse me, Professor. I have a question. Hello, can you hear me?
I can hear you.
Can you go back to slide 44, please?
Let me put it back in.
About the calculation,
Oh,
the previous slide.
okay.
Yeah. On the deficit of sodium, how can we calculate it 8.4 medically over
So that is based on knowing how much sodium is in your extracellular fluid compartment. And so it's a constant that we can say for based on the sodium concentration of your extracellular fluid, anytime you lose 100 mLs from the extracellular fluid space, you're losing 8.4 milliequivalents of sodium with that. And that's why we use the deficit, how dehydrated the patient is, to say, okay, this patient is 10% dehydrated. They lost 500, they're down 500 ml of fluid from their extracellular space. And anytime there's loss in that extracellular space of fluid, there's some sodium lost with it. And so you can memorize that for every that you're going to lose 8.4 milliequivalents of sodium for every 100 mLs of your fluid deficit, because it's what we know is the concentration of sodium in the extracellular space.
All right, thank you. Em có hỏi cô là cái số mà 8.4 mét mất trong 100 ml dịch là cô tính như thế nào? Thì ở cái gần ghi chú ở dưới á, cô có ghi là theo cái Holiday Saga thì mỗi 100 ml dịch nước mất thì mình sẽ mất 8.4 mét natri, thì mình tính tỷ lệ lên bệnh nhân này mất 500 ml thì mình tính tần suất lên thì là 42 mét.
One more question.
Dịch cho.
Từ cái 110 đã làm sao hai cái số 16 cái dịch vô lớn.
Tại vì cái sodium của truyền 110 dịch đó anh nghĩ là chắc là 154 ml đấy. Còn nọc ansalin đó 154 thì anh nhân lên cho 110.
Là 138 tần suất.
110 ml.
Đúng không? Trong 100 con
Xả đi, ansalin có 150 ml natri bình thường đó. Thì tăng suất ra 110 mình sẽ có 16 điểm chứ.
Đúng rồi.
Còn lại là vì là theo công thức Holiday Saga method,
nhưng mà áp dụng cho tất cả
các loại nước thôi, mất nước thôi. I think we have the questions. You can continue.
Sorry, I missed that. You said there are no more questions, or
I think. Yeah.
No, we don't.
Sorry, anyone. I think
We
if you don't
don't
have
have
any
any-
question,
Don't have any more questions. Please continue.
oh, we can. Sorry, it's a little bit late today. Here, can we stop here? We can continue back to next time.
I will have a part 2 where we can just do the hypernatremic dehydration calculation we didn't get to, and then we could do more clinically focused. What are our salt losing tubulopathies? How do we think about potassium as it relates to fluids, which will be more focused on diagnosis and management
In CKD.
in CKD, but yes, we can save that for part 2.
I think it's late here. Can we stop here and we continue back to in July? Thank you, Dr. Denver Rao.
Thank you.
So, thank you a lot for your fantasy presentation. Because it's late in America, so we can stop now. And I hope we can see you again in July for electrolyte. For electrolyte and metabolism disorder in CKD. Thank again.
Yes. Thank you again for letting me present.
Bye bye.
Good night.
Xin các đồng nghiệp, bây giờ bên Mỹ cũng là trễ rồi, tới 11 giờ 10 phút rồi, thành ra là mình kết thúc cái buổi học hôm nay. Thì mình sẽ còn một cái buổi nữa của cô sẽ nói về cái rối loạn điện giải cũng như là thăng bằng rối loạn về toan chuyển hóa ở trong cái bệnh thần mãn ở trẻ em. Thì cái ngày học dự kiến là sẽ là ngày 20 tháng 7, ngày 20 tháng 7 thứ năm, ngày 20 tháng 7 cũng là 9 giờ. Thì khi mà tới cái buổi học hôm đó thì ban tổ chức sẽ nhắn lên cái lịch để cho các đồng nghiệp theo dõi và tránh bỏ sót cái buổi học hôm đó. Thì bữa hôm nay chỉ là nói về cái cách tính rối loạn dịch và điện giải, mà chủ yếu là trong cái tính bù nước và cái sodium trong cái nhi khoa tổng quát. Thì tới cái bữa sau thì mình sẽ nói chuyên sâu, cô sẽ nói chuyên sâu về cái rối loạn điện giải ở trong bệnh thận mạn. Một lần nữa xin cảm ơn tất cả các quý đồng nghiệp đã tham gia vào cái buổi học hôm nay. Cái bài record này cũng như là cái slide của cổ thì chắc là ban tổ chức sẽ xin và sau đó thì sẽ gửi lên trên group để cho các đồng nghiệp có thể tự mình download về để mà mình xem lại ha. Xin cảm ơn tất cả các quý đồng nghiệp đã tham gia.